When you come across a possible medical emergency, what's the first thing you do? It may surprise you that the first thing you do is think about yourself. You need to protect yourself. This is for the sake of the person needing help as well as for yours. After all, if you get hurt, you can't help. Assessing a scene is the process of looking for and avoiding any dangers at the scene of a medical emergency. It's the first thing you do and the first skill you'll practice. Scene assessment takes 3 steps. 1. Stop. 2. Think. And then 3. Act. Stop and assess the scene for hazards. Ask yourself, what caused the injury? Are there any hazards? Look for potential hazards such as leaking gas, chemicals, radiation, downed electrical lines, fire, firearms, the possibility of explosion, or oxygen depletion. Can you make a safe approach? Consider how to make a safe approach. Be alert for possible dangers, such as oncoming traffic. Do you need to turn off a car's engine? Apply barriers as appropriate and if available. Next, think. Formulate a safe action plan. Can you remain safe while helping? Remember that your safety must be the first priority. Know your limitations. What emergency care may be needed? How can you activate local emergency medical services? Can you locate an AED? Can you have bystanders activate emergency medical services or locate an AED? Think about your training and relax. Now act. Begin providing care. To act, follow the emergency care guidelines you will learn in this course. As you help, follow the emergency first response skill sequence of priorities. But scene assessment and taking care of yourself never stops. Ensure your safety so you can help others in need. Earlier, you learned that some people fear infection and therefore hesitate to help others in medical emergencies. The diseases of most concern are those transmitted through blood and other body fluids. These are hepatitis B and C and the human immunodeficiency virus, or HIV. As an emergency responder, you can greatly reduce infection risk by applying barriers. Barriers include gloves, ventilation shields, ventilation masks, face masks, and eye shields. Gloves and ventilation shields or masks are useful during CPR. Gloves, face masks, and eye shields are useful barriers when exposed to body fluids such as blood. As important as they are, however, do not delay emergency patient care if barriers are not available. Research has shown that the chance of disease transmission is very rare when providing CPR. Nevertheless, you can minimize the risk of infection by always placing a barrier between you and the body fluids of the injured or ill person. Like scene assessment, barrier use is a skill that usually comes before you start helping the patient. Remember to begin with skill 1, scene assessment. Stop, think, and then act. As you are assessing the scene, put on gloves if you have them. Put the gloves on carefully to avoid tearing. Removing your gloves once you have finished treating a patient is a bit more involved. Your objective is to remove them so that you don't spray or spread body fluids. To remove the first soiled glove, carefully pinch the outside portion of the glove at the wrist, like this. Next, gently roll the glove off so that the outside portion is turned inside. Hold the removed glove with the gloved hand like this. To remove the remaining glove, place the ungloved hand under the glove at the wrist, next to the skin, and roll off in the same manner. To finish, roll this second glove off and around the previously removed glove, like this. Finally, place the gloves in a biohazard bag for disposal according to local guidelines. Your instructor will show you how to use one or more of the different ventilation shields or masks available. These barriers trap or isolate you from moisture or fluids from the patient's breath and mouth during the rescue breathing step of CPR. Barriers take up little room, so it's easy to keep a set handy at all times. But remember, the chance of disease transmission is very rare when providing CPR. The risk of infection may be even lower if you're helping someone who has a medical history you know, like a family member. Therefore, you may not need to withhold aid just because you don't have a barrier. You've assessed the scene, and perhaps you've applied your barriers. Now you're ready to begin primary assessment. Primary means first in a series or sequence. Assessment is an evaluation or an appraisal. Primary assessment helps you recognize life-threatening conditions and prepares you to provide priority emergency care. By conducting a primary assessment, you will be able to answer the questions, is the airway open, and is the patient breathing normally? This is the AB portion of the ABCABS memory word. After you conduct a primary assessment, you proceed immediately to attend to any life-threatening conditions you discover. No matter what the patient's situation when you arrive, you begin with a primary assessment. Primary assessments all follow the cycle of care sequence that speaks directly to a pathway of priorities for emergency care. Throughout an incident, you continually monitor the patient and use the cycle of care to guide you, ready to provide assistance based on what you learn from your assessment. Watch this emergency scenario, noting how the cycle of care guides the rescuer. After the scenario, we'll review how the rescuer applied each step.
Hello? Ricky? It's Evan. I'm an emergency responder. May I help you? Ricky? Ricky, are you okay? You okay? Yeah, my friend just collapsed. He's not breathing and he's unresponsive. 3234 Tomas Street. Yes. Thanks. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
The cycle of care answers all questions about what injuries or illnesses to treat first. For instance, suppose a patient has serious bleeding and doesn't appear to be breathing normally and is unresponsive. What do you do first? Easy. The cycle of care guides you. First, you assess the scene. Make sure it's safe for you to approach the person in need. Then quickly, seek answers to the questions. Is the patient's airway open? Is he breathing normally? To do this, first open the patient's airway and then quickly check for normal breathing. This patient isn't responsive or breathing normally, so if you're alone, you need to call emergency medical services. Next, immediately begin chest compressions.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
After giving chest compressions, open the patient's airway and begin breathing for the patient. Chest compressions and rescue breaths, CPR, takes priority over serious bleeding. ABCABS and the cycle of care correctly leads you through the priorities of care. In this scenario, you deal with the fact that the patient is unresponsive and is not breathing normally before you treat his serious bleeding. If the patient begins to breathe normally and becomes responsive, then you can attend to his serious bleeding. Let's look at primary assessment, first with a responsive patient and then with an unresponsive patient. A responsive patient is one who is alert and able to answer questions. Begin with assessing the scene. Stop, think, then act. Next, give the responder statement. Hello, my name is, your name. I'm an emergency responder. May I help you? Because responsive patients are talking or making noises other than gasping, you've verified that their airway is open and they are breathing normally, the first two steps in the cycle of care. This patient is responsive and is breathing normally, allowing you to skip over the CAB portion of the cycle of care. There's no need for chest compressions, opening an airway, or breathing for the patient. Keep the patient still. Do not move the patient unless you or the patient's safety is compromised. Put on barriers if immediately at hand. However, don't delay emergency care if barriers are absent. Next, check for serious bleeding, shock, and spinal injury. As you move through the cycle of care, alert the emergency medical service if you find any serious medical condition. Now let's look at the primary assessment with an unresponsive patient. An unresponsive patient is one who is either completely unconscious or one who may be partially conscious but incapable of response. Begin again by assessing the scene. Stop, think, and then act. Make sure it is safe to help the patient. Next, give the responder statement. Hello, my name is, your name. I'm an emergency responder. May I help you? This patient doesn't respond to your statement, so tap him on the collarbone to further check responsiveness. While tapping the patient, ask, "Are you okay? Are you okay?" After delivering the responder statement, quickly check for an open airway and normal breathing. If you are unsure if the patient's airway is open or if he is breathing normally, quickly open the patient's airway using the head tilt chin lift. To perform a head tilt chin lift, first place your hand on his forehead. Next, place your fingertips under the point of his chin, like this. Finally, gently tilt his head back and lift his chin. Another method of opening an airway is the pistol grip, like this. When the patient's airway is open, check for normal breathing. To do this, look for chest movement and listen for breathing sounds. Also, with your ear next to his mouth, feel for expired air on your cheek. This check for normal breathing must be accomplished quickly. If the patient is not breathing normally, he needs CPR immediately. Avoid long delays. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call-first approach to emergency care. You call first to activate emergency medical services, then you provide assistance. This unresponsive patient is breathing normally, so continue your primary assessment by checking for serious bleeding, shock, and spinal injury. If a spinal injury is suspected, keep the patient's head, neck, and spine immobilized and do not move the patient. If no spinal injury is found or suspected, and you may need to leave the patient, place him in the recovery position. The recovery position allows the patient to breathe easier since there is little pressure on the chest. It also decreases the risk of something blocking his airway and allows fluids to drain should he vomit. To put an unresponsive breathing patient in a recovery position, first position the patient's arms like this. Next, grab the patient's far leg just above the knee and pull it up, keeping the foot on the ground, like this. Now, gently pull the patient towards you, putting him on his side. Once on his side, place the patient's lower hand near or under the neck for stabilization. If need be, gently pull back on the patient's head to assure an open airway. If the patient has to be kept in the recovery position for more than 30 minutes, consider turning the patient to the opposite side to relieve pressure on the lower arm. When a patient stops breathing normally and his heart is beating erratically or not at all, you can substitute manual chest compressions for the heart's normal pumping action to circulate blood through the body. The blood you push through the patient's body will carry some oxygen to important organs. Your willingness to respond may increase the patient's chance for survival until emergency medical service personnel arrive. CPR is a two-step process. Step 1, chest compressions, followed by Step 2, rescue breathing. In this skill, you'll learn how to perform chest compressions. If you are unable or feel uncomfortable giving a patient the rescue breaths, relax. Give the patient immediate and continuous chest compressions. Chest compressions alone are very beneficial to an unresponsive patient who is not breathing normally. Your efforts will still help circulate blood that contains oxygen. Begin, as usual, by assessing the scene for safety. Next, check the patient for unresponsiveness by giving the responder statement.
Hello, my name is Penny.
If there is no response to your statement, then tap the patient on the collarbone and ask, "Are you okay? Are you okay?" After delivering the responder statement, quickly check for an open airway and normal breathing. Here's an important note about normal breathing. In the first few minutes after cardiac arrest, a patient may be barely breathing or taking infrequent, noisy gasps. This is often termed agonal breathing, and these gasps must not be confused with normal breathing. Many patients in cardiac arrest make these gasping sounds. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance.
1, 2, 3, 4, 5,
Now, position the patient on his back if not already in this position. If necessary, expose the patient's chest. Find the compression site by putting the heel of one hand in the chest center. On some individuals, this position is between the nipples. Place your other hand on top of the hand already on the chest and interlock your fingers. Use the palm of your hand on the compression site. Keep your fingers off the patient's chest. Next, position yourself so that your shoulders are directly over your hands and your arms are straight. Lock your elbows, like this. Now deliver the chest compressions. Keep the force of the compressions straight down and avoid pushing on the rib cage or the lower tip of the breastbone. Allow your body weight to deliver the compressions. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone approximately 1/3 the depth of the patient's chest, at least 5 centimeters, 2 inches. After each chest compression, release, allowing the chest to return to its normal position. Repeat at a pace of 1, 2, 3, 4, and so on for 30 chest compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard and push fast. With your instructor, you will practice chest compressions using a CPR mannequin. Do not perform chest compressions on someone who does not need CPR. As you've learned, chest compressions alone are very beneficial to a patient who is unresponsive and not breathing normally. However, if you are also willing to provide rescue breaths to a patient in need, you may further increase the patient's chance for survival until emergency medical service personnel arrive. After completing this skill, you should trust your training and provide an unresponsive patient who is not breathing normally with complete CPR, chest compressions, and rescue breathing. As always, begin by assessing the scene and give your responder statement.
Hello, my name is Juanita. I'm an emergency responder. May I help you?
Next, tap the patient on his collarbone and ask,
Are you okay? Are you okay?
After you deliver your responder statement, quickly open the patient's airway and check for normal breathing. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance. As in the previous skill, find the compression site by putting the heel of one hand in the chest center. On some individuals, this position is between the nipples. Place your other hand on top of the hand already on the chest and interlock your fingers, like this. Now, position yourself so that your shoulders are directly over your hands and your arms are straight. Lock your elbows. Now deliver the chest compressions. Keep the force of the compressions straight down and avoid pushing on the rib cage or the lower tip of the breastbone. Allow your body weight to deliver the compressions. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone approximately 1/3 the depth of the patient's chest, at least 5 centimeters, 2 inches. After each chest compression, release, allowing the chest to return to its normal position. Repeat at a pace of 1, 2, 3, 4, and so on for 30 chest compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard and push fast. After delivering 30 chest compressions, quickly position a ventilation barrier on the patient and open the patient's airway. To open the patient's airway, you will use the head tilt chin lift. First, place your hand on the patient's forehead. Next, apply firm backward pressure with the palm of your hand, tilting the head back, like this. Place the fingers of your other hand under the bony part of one side of the lower jaw near the chin. Avoid pushing directly under the chin. Lift the jaw upward to bring the chin forward. This immediately opens the airway. Now, with the patient's head tilted back and the ventilation barrier in place, begin your rescue breaths by pinching his nose closed. Give 2 rescue breaths, with each lasting about 1 second. Provide the patient with just enough air to make the patient's chest rise. Look for this rise in the patient's chest. If you can't make the patient's chest rise with the first breath, repeat the head tilt chin lift to reopen the airway before attempting another breath. Improper position of the head tilt chin lift is the most common cause for not being able to inflate a patient's lungs. Do not try more than 2 rescue breaths to make the chest rise. Minimize delay between chest compressions. After 2 breaths, whether they make the chest rise or not, begin chest compressions again. After delivering 2 rescue breaths, immediately begin another cycle of 30 compressions. Continue alternating 30 compressions with 2 breaths until emergency medical service personnel arrive. You can defibrillate using an automated external defibrillator. The patient becomes responsive and begins to breathe normally. Another emergency responder arrives and takes over your CPR efforts. Or lastly, you are too exhausted to continue. If more than 1 emergency responder is present, consider alternating care. To avoid fatigue, each provider can deliver CPR for 2 minutes and then switch. while switching providers minimize chest compression interruptions. At this point during your training, your instructor may introduce you to the use of an automated external defibrillator, or AED. As you just learned, CPR is an emergency measure that can extend the window during which it may be possible to restart the heart. During this window of opportunity, you want emergency medical services personnel to be on their way to your location. This is why it's important to first call emergency medical services when a patient is unresponsive and not breathing normally. Qualified personnel can provide advanced cardiac life support to the patient. They can help the patient with drugs, artificial airways, ventilation devices, and defibrillation. Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control your heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called fibrillation or twitching. Defibrillation administers a shock that momentarily disrupts the erratic signals and allows the normal heartbeat to return. As time passes, the probability of defibrillation restoring the heartbeat goes down. The benefit of prompt defibrillation was the reason for the development of easy-to-use automated external defibrillators, or AEDs. With AEDs, you no longer have to wait for emergency medical services personnel to defibrillate a patient's heart. AEDs can be used by lay rescuers like you. An AED is a portable machine that automatically delivers a shock to a patient who is not breathing normally and whose heart has stopped beating or is beating irregularly. All AEDs function in the same basic way. First, you turn the AED on by either opening the unit or pushing the appropriate button. Next, connect the AED to a patient via 2 chest pads. When the AED is turned on, its computer analyzes the patient's need for a shock. If the AED detects a heart rhythm in need of a shock, the machine will indicate that a shock is advised. Depending on the type of machine, either the emergency responder shocks the patient or the machine does so automatically. To effectively treat heart fibrillation, you must be able to rapidly integrate CPR with the use of an AED. To give a patient the best chance of survival, 3 actions must occur within the first moments of a cardiac arrest. First, activate the emergency medical services system. Second, provide immediate CPR. And third, use an AED. These 3 actions are all part of the chain of survival. If a bystander is available while you provide the patient with CPR, have them call emergency medical services and retrieve an AED. Further, bystanders can set up the AED and apply the chest pads while you continue CPR. Overall, both of these bystander actions allow you to minimize interruptions in CPR.
Himself on the saw. Can you call for help and wait outside for them till they get here and bring him back?
Okay.
Thanks.
Can I help with anything?
Yeah, could you get the first aid kit, please? Yeah. Thank you. Okay, try and elevate from here. Okay, try and keep your arm elevated here. Great, thanks. Great. Continue in area. Thanks. Okay, great. Saw here. Look at this.
Control of bleeding is a basic but important first aid skill. By controlling a patient's serious bleeding, you can positively influence a patient's outcome. Serious bleeding is life-threatening because blood carries oxygen to the body tissues. The body holds about 6 liters or quarts of blood, and losing even 1 can cause death. There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessel and carry blood from the heart to the tissues. Arterial blood is bright red and spurts with each heartbeat. Arterial bleeding is the most serious because the patient can lose a lot of blood quickly. If a major artery is cut, death can occur in 1 minute if not treated. Activate the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark red and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the patient's cycle of care. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding tends to be slow and easily controlled unless the injury covers a large area. Monitor the patient's cycle of care and contact the emergency medical service if necessary. To begin helping a patient with serious bleeding, first assess the scene to make sure it's safe for you to approach. Put on appropriate barriers and deliver your responder statement, asking the patient if you can help. If the patient says yes, call emergency medical services. Reassure the patient as you treat for bleeding, and if needed, assist the patient into a position of comfort while treating. Since the patient is responsive and breathing normally, you can sidestep CPR, chest compressions, opening an airway, and breathing for the patient. With a responsive patient, proceed immediately to the S in ABCABS on the cycle of care. The first S in ABCABS prompts you to check for serious bleeding. To control serious bleeding, use sustained direct pressure. Put a clean cloth or dressing on the wound and apply constant pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. Maintain the pressure continuously, but you may periodically release pressure to see if the bleeding has slowed or stopped. In addition to sustained direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. The patient may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Applying sustained direct pressure and pressure bandages best controls bleeding. However, there may be regional treatment variations, such as elevating bleeding limbs, giving the patient oxygen, and applying a tourniquet as a last resort to controlling serious bleeding. Your instructor will advise you of these variations. Shock is the body's response to serious injury or illness. Shock can be life-threatening and happens when not enough oxygenated blood reaches the body tissues. This occurs due to serious bleeding or when the body no longer regulates blood flow to the tissues. In general, always treat an injured or ill patient for shock, even if the signs and symptoms for shock are absent. There are 9 indications of shock, though some occur with other injuries. They are rapid, weak pulse, pale or bluish tissue, moist, clammy skin, possibly with shivering, mental confusion, anxiety, restlessness or irritability, altered consciousness, nausea, and perhaps vomiting, lackluster eyes, dazed look, and shallow but rapid labored breathing. By the time you get to shock management, you will have progressed well along the cycle of care. You will have assessed the scene and applied your barriers. Through primary assessment, you would have confirmed the patient's level of responsiveness and that he is breathing normally. Since the patient is breathing normally, there is no need for CPR. If the patient is unresponsive or bleeding, you would have already alerted the emergency medical service. If he were bleeding, you would have treated him by applying direct pressure. To treat a responsive patient in shock, let the patient determine what position is most comfortable, sitting or lying down. To treat an injured and unresponsive patient, do so in the position you find him. If there may be a head, back, or neck injury, don't move the patient and keep his head and neck immobile. more on spinal injury treatment in the next skill. Regardless of whether the patient is responsive or unresponsive, to treat for shock, maintain the patient's body temperature based on the local climate. This may mean covering the patient with a blanket or exposure protection from the sun. If there's no reason to suspect spinal injuries or leg fractures, elevate the patient's legs 15 to 30 centimeters, 6 to 12 inches. This shifts blood to the more critical chest and head areas. Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. Moving a patient with a head, neck, or spine injury may make the injuries worse. Therefore, never move a patient with a suspected spinal injury unless absolutely necessary because of imminent danger. With a responsive patient, conduct your primary assessment where you find him. You would only move the patient to avoid immediate further harm, such as if the patient were in the water or a burning car or building.
Take it easy, okay?
You would also move the patient, if necessary, to provide CPR. You should suspect spinal injury with situations that cause injury to the head, neck, or spine. These include auto accidents, being thrown from a moving object, falling, especially from a height higher than the victim, a penetration wound, such as a gunshot, any severe blow to the head, neck, or back, an accident that includes hitting something head first, such as diving into shallow water, lightning strike, or any severe impact injury regardless of what part of the body was struck. 8 indications that a patient may have a spinal injury are change of consciousness, difficulty breathing, vision problems, inability to move some or all of the body, paralysis, headache, vomiting, loss of balance, tingling or numbness in the extremities. For an unresponsive patient, start by assessing the scene for danger. Put on appropriate barriers if available, and begin to conduct your primary assessment. Conduct your assessment with the patient in the position you find her. Unless the patient's safety is in question, she might need CPR, or you need to control serious bleeding of a wound you can't see. Deliver your responder statement and have someone call emergency medical services.
Call for help.
The patient must be on her back for continued care. If she's not already on her back, you'll have to turn her while minimizing risk to her spinal cord. You want to stabilize the head and neck so that as you turn the patient, they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the patient all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you under her hip, and while supporting her head, roll the patient toward you. Gently ease the patient onto her back and continue with the cycle of care by starting CPR if the patient isn't breathing normally. If the patient is breathing normally, check and treat for serious bleeding, shock, and spinal injury. In a primary assessment, you've learned how to apply the cycle of care to ask 2 initial questions when someone is in need of emergency assistance. Is the patient's airway open, and is he breathing normally? When a responsive and conscious patient is choking, they neither have an open airway nor are they breathing normally. A choking patient needs immediate help to restore breathing. In adults, the most common cause of choking is food. Let's learn how to help a conscious and unconscious patient expel an object that's causing him to choke. If you believe a person is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive patient,
"Are you choking?"
If the patient is coughing, wheezing, or can speak, encourage the patient to cough until he expels the object. If the patient cannot speak or breathe, give the responder statement and alert emergency medical
"I'm an
services.
emergency responder. May I help you?" "All right, take it easy."
After the patient indicates he wants your help, a nod will do. You may use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. Techniques for handling a conscious choking patient vary internationally. Your emergency first response instructor will teach you the techniques appropriate for your area, and it's those you should use when assisting a choking patient. In general, however, there is no clear evidence that one technique is better than another, but there is evidence that if one technique does not help a choking patient, then another one might. To deliver back blows, take a position to the side and slightly behind the patient. Supporting the chest with one hand, lean the patient forward. Next, firmly strike the person between the shoulder blades with the heel of the other hand 5 times. Stop if the obstruction clears or move on to another technique. Abdominal thrusts use residual air in the patient's lungs to blow the obstruction clear. Stand behind the patient with your arms around her waist. Find the patient's navel with one hand. Make the other into a fist and place the thumb side against the patient's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the patient's ribs, pull your hands inward and upward in a thrusting motion. Stop if the obstruction clears or move on to another technique. Abdominal thrusts may not be possible with some individuals, such as those who are pregnant or markedly obese. In these cases, provide thrusts in the center of the chest. Use your fist with the thumb inward and the other hand on top, just as you do with abdominal thrusts, but put your fist on the same site where you would perform a CPR compression. Continue using one or more of these techniques until the obstruction is relieved or the patient becomes unconscious. When you practice these techniques, be sure to simulate thrusting. Never perform thrusts on a person who does not have an obstructed airway. If a responsive choking patient becomes unconscious while you are trying to help, carefully help the unconscious patient to the ground. Next, activate emergency medical services and immediately begin CPR, chest compressions. The compression should dislodge any obstruction. Following the chest compressions, you should quickly look inside the patient's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. Continue CPR until the obstruction is relieved and the patient becomes responsive or emergency medical services arrives. Depending on local guidelines, restrictions, or laws, your emergency first response instructor may be able to offer a skill development session on emergency oxygen use. Receiving adequate oxygen is crucial, especially after a serious injury or illness, near drowning and scuba diving incident, plus continued exposure to altitude. You can decrease patient stress and support the respiratory system by administering emergency oxygen. You may want to seek additional and more advanced oxygen training if you are a scuba diver or you frequent locations that offer aquatic activities. Now that you understand the 9 primary care skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts the cycle of care to the realities of the situation.
Grandma, are you okay? What happened? What's wrong? What happened? Hang on,
Stop,
everything's gonna be okay.
think, and then act. Is there a hazard here? The emergency responder sniffs for gas and confirms the gas stove is turned off. The caregiver delivers the responder statement and gets emergency care on the way.
Do you need help? It's okay, I'm an emergency responder. May I help you? Jimmy, come here quick. It's okay. What's wrong? I don't know. Something's wrong with Grandma. Go call for help. Tell them we have an emergency and then come back and tell me what they say.
I'll call and come back.
It's okay, Grandma.
The emergency responder monitors the patient and uses the cycle of care to guide her. She's responsive and breathing, so there's no need to provide CPR. Further, there's no evidence of bleeding.
Help will be here soon.
Help me put her in the recovery position. Put her leg a little bit forward. Go get the pillow and blanket on the couch. Go wait for the ambulance outside.
The emergency responder treats for shock and continues to monitor the patient until help arrives.
Be okay. Help is on the way.
The emergency responder stops, assesses the scene, thinks, and then acts.
Hey, this is Fabio, an emergency responder. May I help you? May I help you? Are you okay? Are you okay?
The emergency responder finds the patient unresponsive. His airway is open, but he is not breathing normally.
Hey, Sherilyn. This is Fabio. Listen, I'm in room 3. RF is down. He's unresponsive, and he's not breathing. I want you to activate the company emergency plan. Then I want you to call emergency services and direct him here to room 3.
Using the cycle of care to guide him, he calls emergency medical services and immediately begins chest
1,
compressions.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 5, 6, 7, 28, 29, 30.
The emergency responder provides CPR until emergency medical personnel arrive.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17.
A medical emergency with more than one patient and only one emergency responder requires some thought. You can only do so much, so do the best you can. Stop, think, and then act.
Yeah, I need to report an auto accident on the corner of Alton and Pacific. It looks like you might have a couple injured passengers. Yeah. Yeah, okay. Sit tight, all right? Help's on the way.
The emergency responder approaches the scene cautiously, keeping himself safe and watching for hazards as he approaches the scene.
Hey, my name's Matt. I'm an emergency responder. May I help you?
Yes,
Well, where do you hurt?
on my head. I'm okay.
Okay, I want you to try not to move it, okay? Let's wait till the medical crew gets here so they can check you out. All right? It looks like your passenger may need some help, so I'm gonna go take a look at her. So just sit tight and relax, all right? I'll be nearby. you doing? You okay? You all right? Just relax, okay?
The emergency responder uses the cycle of care to guide him and begins to treat this patient's serious bleeding. Notice that he continues to monitor the patient while maintaining continuous direct pressure on the wound.
How's your head feel?
The same.
Okay,
The
just relax.
emergency
I'll find its
responder
way.
asks this question of the first patient as a simple way of checking to see if he is still responsive and breathing.
Is there anything that I can do?
Are you a trained emergency responder?
No.
That's okay. You know what? You can put on this extra pair of gloves I have here.
Okay.
Try and lay still, okay? Keep your head still for me. What I need you to do is I need you to put pressure on this wound here, okay? If you need another bandage, go ahead and take one out of that box and put it right on top of this, all right? Keep pressure on the wound the whole time. Okay, so when I take my hands off, go ahead and replace them with yours, okay? Here we go. Good.
The emergency responder continues to use the cycle of care to guide him and monitor both patients until the emergency medical service providers arrive.
There you go, lay still. Okay, keep pressure on there.
Okay.
Okay, try and relax, okay? I'm gonna hold your head until the ambulance gets here.
All right.
Sit tight, all right? The guys are here.
How many people do we have in the vehicle? One?
Just two.
Two, that's it. Anyone ejected? Anyone else in the vehicle? No?
Came on these guys.
No, that's it. Okay, what do you have right there?
As you saw, having more than one person at the scene increases the aid available. By encouraging your family and friends to complete the emergency first response courses, you increase the chances there will be more than one emergency responder at hand in a medical emergency. As an emergency responder, you play a crucial role in a medical emergency. In life-threatening emergencies, you provide the critical first links in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Most emergency responders will never need their skill, but practicing them and reviewing this program will help you be ready to reach out and help another in need should you ever need to.